Perfect, John. Thank you very much. Right, well, we're pretty much set up, chaps. I can see you both, can hear you both, and I've got your slides full screen. See you in 20 minutes from Q&A, and cheers again for getting involved.
Perfect, excellent, and thanks very much, Sean. So good afternoon, everyone, and welcome. So my name's Alex Harvey, and I'm VP of Sales with Spacestor Healthcare. I'm really excited to be co-presenting today with John Hyam from Birmingham Community Healthcare Trust. So he's going to introduce himself shortly, but it's been great to join today's forum. Firstly, thanks to Convensis for hosting, and to all the other speakers. I've certainly found some fascinating insights in what we've heard so far around all the ideas and initiatives and products that are driving the transformation, as well as the overall vision that we started off with at the beginning of the day from Andrew Wilkinson from NHS England. So let me introduce you to Spacestor Healthcare. Spacestor are the creators of workplace furniture that's a blend of California cool and London design. The business is located here in the UK and has been for nearly 30 years, as I say, creating workplace furniture. And then around 10 years ago, we opened our first location in the United States, which enables us to work with and support our clients globally. And one of the areas of specialism with Spacestor Healthcare is in the design and creation of furniture. And over the last 5 years, that's taken a particular focus on the creation of modular, acoustically enhanced spaces for phone, and then more recently for video calls. So we've heard a lot about the software and the apps that allow virtual consulting to happen. But now we're going to look at how the environment in which those calls can happen, how those environments can be created, how they can be scaled rapidly and effectively. So as I said, Spacestor work globally with many corporate clients in their workplace settings, clients such as Google, Spotify, Amazon and Microsoft. And of course, not just tech firms, we also work closely with other manufacturing firms such as Tesla, pharma and healthcare companies like Pfizer, AstraZeneca and Merck. And we've seen a really interesting trend over the last 5 to 7 years, something that's actually been accelerated during the last 18 months during the pandemic. And we've seen companies focusing on a concept called activity-based working. Now, activity-based working was a concept that was first discovered in the 70s. And really what it is a concept that recognizes that people need to perform different activities in their day-to-day work, and therefore need a variety of different work settings supported by the right technology and the right culture to carry out these activities effectively. So what does that all mean in real life? Now, I thought I'd give you an example that we all know well, because this is how we intuitively use our homes. We have different settings, we have different rooms for different types of activities. So for example, we have the kitchen for preparing food in, we have your bedroom for sleeping in, we have your living room for entertaining and relaxing. And in the same way as you wouldn't prepare a meal in your bedroom or in your bathroom, we've seen a rapidly emerging awareness of the need to provide the right kinds of environments within those workplace settings, so particularly around video calls or virtual consultations. And what we've seen is, particularly in the corporate environment, the open plan space isn't a suitable or a professional space to take video consultations from, both from patient privacy and confidentiality, as well as the patient themselves not being comfortable with having a clinical conversation where they could maybe see or hear other staff in the background. So one of the previous speakers was talking about seeing the right patient at the right time. And I'd like to add to that, I think we also need to make sure that we're seeing the patient in the right place. So how does this all fit into the world of the NHS trusts and healthcare that we're talking to today? Now, our modular pods at Spacestor include a world first, the first ever pod designed from the ground up specifically for video. And whilst we have many options dependent on the use case for either phone or video consultation and dependent on the job to be done, what we started to hear during many NHS trusts during 2020, they were reaching out to us and saying, the products that you're designing and developing for your workplace clients, for the likes of Google and other firms that we talked about earlier, could they be provided into the NHS environment? And the purpose behind this really was around reducing waiting lists and ensuring, at the core of it, ensuring that the space availability doesn't become the constraint to increasing the number of patient consultations. So what we've been able to do is provide these rapidly deployable and future flexible acoustically enhanced private spaces to allow phone and or video consultations to happen. And this has a number of real benefits to the trust that we're working with. So firstly, this is a furniture item, so that means it's potentially very tax efficient to the organisation from an implementation point of view, as well as if you're at a PFI building, it means that there's minimal impact to the building infrastructure itself. It's very fast to deploy, so the creation of one of these modular rooms would be less than half a day to install and commission. So therefore, there's minimum disruption, minimum downtime. And of course, allied with that, we have the baked-in future flexibility, the ability to move and shift and dismantle and relocate this modular pod in the future should your needs change, should your organization change, maybe should your spatial needs change. And we talked a lot about the sustainability impact that virtual consultation brings from a point of view of reduced carbon and reduced travel miles. But along with that, we also have the sustainability impact from the built environment. So we're not building rooms which in the future may be demolished and all the drywall would then go to landfill. This is a modular solution which can be 99% recycled, reused and reconfigured in the future. And of course, using a pod like this for a video consultation specifically, it means that we're reducing the space that the clinician needs when they're carrying out that video call, I should say. So in a traditional clinical room, which is upwards of 16 square meters, if you're carrying out just video consultations, you could actually be carrying out the same conversations with the same level of privacy, the same level of confidentiality in a space that's 2.1 square meters. So I'm going to hand you over to John Hyam now, who's going to talk you through the experiences that Birmingham Community Healthcare Trust have had, and then we'll continue the journey. So over to you, John.
Thanks, Alex. So if we move to the next slide, this is the main foyer of our trust headquarters, and that's where we installed our pod for the trial. And I'm going to talk to you about our journey with the pod, but also our journey with remote consultation more generally. Next slide, please. So what have we done with remote consultation? Well, in common with many other NHS providers, we moved towards remote consultation as a response to the COVID pandemic. Initially, that was through increased telephone consultations, but we took part in the national offer of Attend Anywhere video consultation and implemented that from April last year. And our aims really were to keep our staff and service users safe and maintain our critical clinical services during the pandemic. But we're now looking at what's the opportunity post-pandemic, and we really see this as an opportunity to embed remote consultation as part of our normal service offer. Next slide, please. So how are we using remote consultation? I think it's important to recognise that telephone consultation is still valuable. It's very simple and easy to use for clinicians and patients, and it's very accessible. And so where it is safe and effective, I think we should continue to use it. But it's also important to recognise that video consultation has added benefits, particularly in terms of having sight of the patient and be able to pick up on non-verbal cues. And building that rapport, but it doesn't work for everything. Particularly if you need to lay your hands on a patient, examine them, then face-to-face is better. And so where we consider it appropriate, we will use remote consultation, but we will escalate to face-to-face if it's not considered appropriate clinically or if it's not accessible by the service user. Next slide, please. So this is just an overview of our implementation approach. I'm not going to go into great detail, but in the first phase, we just wanted to get it out there and get our services using the platform. In the response and recovery phases of the COVID pandemic, we actually picked up on quite a lot of the governance around the project, that if we were doing a normal technology implementation and transformation, we would have had in place at the beginning of the project. But now we're moving into phase 3, which is very much looking at what our new normal will be. We're looking at co-production of our business as usual offer with our service users. We're also looking at staff engagement, sharing good practice, but then a big thing that we really want to focus on is addressing digital exclusion, and that's where our journey with Spacestor comes in, and I'll talk to that in a while. So the next slide, please. So this is just some activity data to give you an idea of what we've been doing with remote consultation in our organisation, and it's presented as actual data and ratio. And if we look at the actual data, we can see a drop in activity across the organisation from March 2020 and that was as our clinical staff were redeployed across the system to respond to the COVID pandemic. You can see that pre-pandemic, we were doing about less than 5% of our activity with remote consultation, the purple bar, and that was by telephone. Post-pandemic, that increased rapidly to around 20 to 25% of overall activity. From April 2020, there's been a gradual increase in Attend Anywhere video consultations, which is the red bar. The green bar is Microsoft Teams. We have to use that for group consultations, but really we're focusing on the red bar. We've achieved around 5 to 10% of our overall activity. If we move on to the next slide, the overall activity isn't the full story, because actually we've demonstrated in some of our services how far you can go with remote consultation. And one of those services is the service that we initially piloted video consultation with, and that's our children's speech and language therapy service. And you can see that they had a drop in activity in common with the rest of the organisation, but then really quite quickly recovered that towards the end of last year. And most of that was delivered using remote consultation. And we're now in a position where the remote consultation offering that service is fairly evenly split between video and telephone. And interestingly, if we look at November 2020 and December 2020 and compare it to the same months in 2019, you can see that the service is overperforming against historic data, and that's in the context of the second wave of the COVID pandemic, and that's been largely achieved through remote consultation. Next slide, please. We have quite a rich data set on patient experience, and when we asked patients whether they felt their needs were met, then over 90% were very positive or positive about their experience with remote consultation. When we asked them about the service they received overall, again, over 90% were reported it to be very good or good. Next slide, please. When we look at data that we've collected on protected characteristics, I think this is interesting because we wanted to actually identify the communities that we may not be serving with these technologies. And one of the concerns that people often have is that age is a barrier to accessing technology. And I think that's true to an extent, but I think it's probably slightly over-egged and something of a myth. And so if you look at our data, the peak usage is in the 31 to 50-year-old age group, but actually reassuringly, our second peak user group is the 51 to 71-year-old age group. We're seeing less usage in the 71-year plus age group, and that's something that we need to look at going forwards and see if we can mitigate. And interestingly, we're seeing quite a low level of reporting of children, but actually this is a self-reported survey, and we realised that the parents of the children were entering their own age into the survey, and that accounts for that. And it probably accounts for the disparities that we're seeing in gender as well. Next slide, please. In terms of ethnicity, this is actually largely reassuring. So if you compare our data from our survey responses with our ethnicity data from the 2011 census for Birmingham, they are very closely comparable. We just need to be mindful that, you know, it's the 2011 census data and we need to monitor that going forwards. Next slide, please. So as part of our process of engaging with our service users, we arranged a public engagement of people who had been contacted through video consultation. It was a virtual coffee morning on Microsoft Teams. And overall, they were very positive about their experience, and they were really keen that we maintain video consultation as an option going forwards. They did raise some concerns about digital poverty and potentially excluded communities. They also talked about patient choice, because actually the way we'd been using these technologies in the pandemic, we hadn't really been giving much choice, and going forwards, that's something that we clearly need to reintroduce. And there was also comments around the impact of the pandemic on the positive feedback that we'd received. And they actually talked about how grateful they were to receive an appointment at all, given the pressures on the NHS, that they may have actually exaggerated the positive feedback that they gave us. And so that's something that we are monitoring going forwards. And interestingly, we haven't seen that much of a drop-off as the context has changed. But overall, they very much supported a hybrid service delivery model going forwards, and they want us to maintain remote consultation as an option. Next slide, please. I think we have to then look at our clinician feedback, which is much more nuanced, and acknowledge that there is a disparity there. So when we talk to clinicians about being able to capture information during the consultation, the majority, around 60%, said yes, but a significant minority said no. And then when we asked clinicians whether it was an appropriate tool for their appointment, around 49% said yes, but a significant minority said yes, but only under the circumstances of the pandemic, and actually they prefer face-to-face. And a significant minority, again, around 20%, said no, it wasn't appropriate. And we think that this is partly down to the way we were using remote consultation during the pandemic. We weren't being very selective, and so actually we think as we change going forwards and actually are giving clinicians the opportunity to say, well, that's appropriate for a remote consultation, whereas I need to see that patient face-to-face, that we should see a change in this metric. And we also think this data actually represents the culture change that's happening, and clinicians have not been trained to deliver care by remote consultation. We were trained to deliver care face-to-face and hands-on. And so it is a significant culture change, and there's an OD piece around that. Next slide, please. And I think this has been talked about in previous presentations today, and thinking in terms of sustainability, this is a high-level benefits analysis from NHSIE. I'll just draw your attention to the impact on travel miles saved and the CO2 emissions from the consultation delivered in our trust. Next slide, please. So I want to focus in on digital exclusion because we are concerned that we may be excluding members of our community, and when we engaged with our community, they were concerned about the same issue. So to try and address this, we've reached out to local library services in Birmingham and Birmingham City Council around the health literacy piece, and also about potential estates across the patch. We have engaged with our ICS, and we're looking at how we develop a unified strategy to mitigate digital exclusion. But then we have we're offered the opportunity to trial the virtual consultation pods with Spacestor, and we were very keen to engage with that. And so we trialed it with our clinicians, primarily physiotherapists, but we also trialed it with our patients. And I'm going to take you through some feedback from that trial. Next slide, please. So when clinicians trialed it, they actually really loved it. They thought the feedback that we received was generally positive. They liked the way it was built. They liked the feel of it. They liked the functionality. But they did raise some concerns about soundproofing, and that actually turned out to be an issue of the installation, which was very quickly fixed. But they also commented that actually it's not big enough for them to demonstrate exercises to their patients. And we'd actually selected one of the smallest models, and we then had the opportunity to change to a larger model and trial that instead, and actually the feedback shifted based on that. They did comment that even with the larger model, it would be quite a small space to have to work in for more than one session, but they were quite comfortable to work in it for a session. And we can just look at how we job plan people as we go further using the pods. Next slide, please. Patient feedback was also really good. We brought patients into our trust headquarters, and they were booked for a remote consultation, and they actually had that remote consultation delivered in the pod, and they were supported by our lead of patient experience through that process. They talked about how it was an excellent concept. They also commented about size, and they commented that you wouldn't be able to fit more than one person in there. So what would you do if you had a patient or carer or relative? But that can be addressed by having a larger size of pod. They also said it wouldn't be large enough or accessible enough for a wheelchair user, but there are pods that are optimized to do that. And that's something that we're looking at as an option going forwards. At the moment, it's a glass door and people can see in, and actually for clinical consultations, they said there would need to be a privacy screen, again, something that we can address through the co-design process. Again, they raised the issue about the soundproofing, but we fixed that. But they also talked about how we would operationalize this. So would there be staff on hand to wipe it down after use? Would there be someone there to greet them? So we'd have to, if we were going to distribute these pods around our ICS footprint, we'd have to think about where we would put them and what we can plug into in terms of human resources in that footprint. And so it would be about working with in partnership with other organisations. They also talked about having a touchscreen monitor, because actually we used a laptop. And that was so that our clinicians could use it, and as well as the patients trialing it, but that's something that we can look at in the design process. And I'm just going to share with you a comment that we've taken from the narrative feedback. I'm not going to read it out to you, I just thought it was a really nice comment, and it made me smile, so I hope it might make you smile too. Next slide, please. So in terms of digital exclusion, where are we going next? We want to continue to trial the Spacestor pod, and we've actually purchased one to enable us to do that, and not just in isolation. We are in the process of offering the opportunity to trial it to ICS partners. We're going to get our estates team to learn how to dismantle it and reassemble it so that we can move it around where we need to. But we realise that as an NHS organisation, we can't do this on our own. This is too big for a single organisation to address. So we want to work with our ICS partners to agree a strategy to mitigate this together. But as part of that, Spacestor are really keen to engage in design development, and that's particularly focused around supporting the use of these pods out in the community. So can we have a digital lock so that we can have control access to the pods, and can we have remote monitoring and observations devices so that we can actually increase their functionality and increase their clinical utility. Next slide, please. So I'm going to pass you back to Alex to talk about where we think we could use them in the community and how we might use them in the community.
Yeah, thanks, John, and thanks for sharing the journey so far. So as John has already said, Spacestor have been working with BCHC and other trusts to look at how other stakeholders, maybe beyond the secondary care, beyond outpatient departments, could benefit from this kind of product and how we could meet other challenges. So we talked already about tackling digital poverty. So the opportunity of maybe placing this kind of video enabled pod into libraries or supermarket atriums or possibly shopping malls, so that actually any user could be sent a text message which will give them a code to open and unlock that pod to access that for a specific consultation or appointment. We've talked about placing pods into GP or other primary care providers. John mentioned earlier about remote monitoring devices or some kind of observation devices. And we've also thought about placing or introducing these pods into schools so that we can support the nursing services, and ultimately to mean that students don't need to lose their valuable teaching time, not to say also the parents who may have to take time out of work or out of their busy days to take their child into hospital. But John, I know you've had the opportunity to look at this and given it a lot of thoughts. You could probably say further about the education application.
So, I mean, we've already been using Attend Anywhere for school nursing drop-ins. So we've had the services developed posters with a QR code that will take students to a waiting room if they want to drop in and talk to a school nurse remotely. We could really optimize that if we had a space there where students could go and it was private. And then there's probably a wider piece about engaging with partners across the ICS and education authorities in thinking about, well, what more can we do? And you know, operationalizing that might be quite tricky, but there's definitely a potential opportunity there to think about, well, do children have to leave school to be able to access healthcare? outside of school nursing services, and there's lots of factors that you would have to think about to make that work, and some of them might be insurmountable, but I think it's definitely something that we should be looking at and considering. So I'm just going to talk about some of the opportunities that we've identified with remote consultation. So wherever we think that the way forward is hybrid models of care, including telephone, video, and face-to-face, and actually having a process of escalation, but also clinical selection, and also factoring in patient choice in that decision. We have demonstrated in our services that there is a role for remote consultation in managing waiting lists and backlog recovery. There's also an element around access to care. Some of our services have very wide catchment areas, and some patients simply don't want to travel, and actually some of the narrative feedback that we've got from patients is actually how easy it is for them to access care without having to take time off work, etc. There isn't a piece about the patient experience and the patient's choice. We have to acknowledge the feedback that we've received and look at that and say, well, it's extremely positive. They like it. They want us to keep this as an option and a tool in our tool chest. So we need to respond to that. There's some really tentative but very interesting feedback that we're getting from some of our services about potential clinical benefits from video consultation, particularly from our speech and language therapy service and occupational therapy service working with children. Talking about working in the home environment with the children being surrounded by their family and their own belongings, and how that has advantages in terms of the clinical encounter. There is a piece around estate rationalisation, and we're not there yet, but I think as we go further along this journey, we need to think about how we are utilising our estates. We have a lot of open plan offices, so if we're going to be able to offer video consultations from our estate, then we probably need to think about how we use those more flexibly, and the pods do fit into that overall strategy. We also need to think about the cost of very expensive clinical estate, and actually if we're reducing our overall face-to-face activity, do we need to maintain the clinical estate that we already have? And there are definite HR implications, and we've already started on this journey, and really excitingly, we're managing our speech and language therapy backlog by appointing locums from all over the place, all over the UK, and actually we've got someone delivering care from Spain via video consultation. And so they're clear advantages, but I think it's important to recognise that there are challenges as well. Next slide, please, Alex. And you know, we have to recognise that the staff feedback is not as positive as the patient feedback, and we need to look at why that is. And I talked earlier about, well, it's how we were using it, and that should improve as we use it more selectively. But also it's about the change management process and actually taking our staff on a journey, and I hesitate to say retraining, but actually there are different skills at play in video consultation when compared to a face-to-face. I think there is an element of concern around organisational resilience and business continuity, because these are maturing technologies. They're not fully mature, and they don't work perfectly all of the time. And what does that mean in terms of continuation of the consultation? Our clinicians have definitely raised concerns about the equivalence of remote consultation and face-to-face contact. And I think it's important to say that they don't have to be equivalent, and actually you design your pathway to mitigate any equivalence issues. But one of the problems that we have with that is that there is very limited evidence out there talking about equivalence. So what we're doing at the moment is we're engaged in an academic evaluation to try and provide some evidence that talks about that. There is a perception amongst our staff that remote consultation is COVID only, and that after COVID we'll get back to normal, and I don't think that's true, and actually I don't think that's something that we would want, because do we want to sacrifice the ground that we gained? I mean, I started as a CCIO 3 months before the pandemic, and I would never have predicted that we would be in this position with remote consultation 2 years down the line. And actually I think we need to see that as one of the positives that's come out of the pandemic, but we need to be creative about how we use it. And then for us to enable that, we need to really tackle the issue of digital exclusion. And we don't want to be implementing these technologies if we are going to exclude members of the communities that we serve. Next slide, please, Alex. So where next for us? Well, we think that remote consultation is here to stay, and we're building it into our post-COVID new normal. And to do that, we want to build more staff engagement and share good practice. We've been doing that, but we want to go further. And to support that, we want to address the issue of digital exclusion. And I'll hand you back to Alex after the acknowledgements. So this has been a huge team effort, and people from all over my organisation, but also in the region, as well as our partner Spacestor, have helped us on this journey.
Good. Well, thanks, John, and thanks for sharing your experiences. So that brings us to conclusion. So I guess in terms of a next steps, Spacestor Healthcare are continuing the work that we've been doing with BCHC and with other trusts. We're actually running a draw, so one lucky winner will have the opportunity for a free, no commitment trial for one of these modular pods that we've been talking about. So you can use the URL on the screen in front of you, or you can scan the QR code. So that's spacestorhealthcare.com/trial. And we'd also love to invite you to be involved with the journey that we're currently embarking on. So perhaps you're involved with a trial of this type and you've learnings you'd like to share. Perhaps you'd be interested in some further information around the trials that Spacestor and other trusts have done. Or perhaps you'd like to contribute to the data set that we're building. So as we kind of started with at the beginning, I think we have a once in a generation opportunity to create a better world of healthcare. And Spacestor Healthcare would love to be part of your journey. We'd love to support you with the outpatient transformation work that you're doing. So that brings us to the end of the presentation, and we'd love to take any questions you have. So back over to you now, Sean.
Yeah, there's no shortage of questions anyway, chaps. So yeah, thank you for the presentation. It's been really, really well received. So we'll just crack on. We'll get through a few. Last poll of the days on the screen now for everybody. Please do get involved in that one. So as we go forward here, so Ruth has asked two questions. First one, how are the pods cleaned between consultations if remotely located?
And that was something that came up in our trial with the patients, and I think we're not at that stage yet. We're at the early stages of working out how we might implement that, and it would be about engaging with partners. So one of the things that we're looking at is if we were going to remotely locate these, we would do it across the ICS patch, and we would do it in partner organisations. So one of the first things that we looked at was, could we do this in libraries? They already have computer clusters, and they also already have a health literacy remit. Yeah. And so can we do that in partnership, and can we get them to help us deliver that? And you know, that's one of the, as we move towards integrated care systems, that seems to me one of the clear ways that we might want to be working together to support on a project like this.
Yeah, Alex, do you want to pop anything in? I've got a bit of a backup there because someone else has asked, but do you want to pop in on that at all?
No, as John said, it would probably depend a bit on the location and what existing cleaning regimes they may have in place. One thing we've looked at with some of our corporate clients is also having some kind of self-service, you know, just internal antibac wipes where you can actually do the cleaning yourself if you wanted to do it that way as well.
Yeah, no worries. Ruth just followed up with she was imagining a version of a self-cleaning toilet. If you've ever seen them before, so thank you for that, Ruth. That's brilliant. So Ruth just asked another one as well. Exclamation marks in the end of that. Brilliant. Ruth just asked, how do your pod teams access patients' medical records and notes for each session?
So the clinicians.
Yeah, well, she's put the pod teams, but I assume it's the clinicians who would need that. So yeah. Yeah,
so I mean, the clinicians are working on trust devices and have access to our electronic patient record, etc.
Yeah, access pre-consultation. Right, Kelly, how much does a fully functioning installed virtual room pod cost?
So that probably depends a bit on the actual pods. So we've got a number of different pods depending on the use case. So from a kind of smaller one to the much larger one that we spoke about, or that John spoke about, that BCHC are using. But you'd be looking at an installed price of between about 12,000 and 18 to 20,000. As I say, there are a number of different options. So we could discuss that specifically with individual requirements.
Perfect. Cheers, Alex. Brilliant. That's great. And so Jacqueline, it's quite an interesting one after what you were saying there, John, about the library. So Jacqueline has asked, we have mentioned digital poverty and creating digital hubs. Could these units go into local venues, libraries, day centres, etc., enable patients to use IT if they haven't got access at home? Cost of the unit may be an issue, but maybe funding could come from the savings from F2F consultations. Thank you, Jacqueline. Brilliant points and question.
And that's absolutely how we would anticipate funding it. So as you rationalise your estate and reduce clinical estate, then potentially you can plough that funding into creating digital hubs so that people can access these. And I think the future work, so the design stuff that we talked about, introducing remote observations and monitoring, so things like digital stethoscopes, etc., that's actually increasing the clinical utility. So it isn't just for people who don't have access to an internet-enabled device. Yeah. It's also for other people as well. Because, I mean, there are issues about how you implement remote monitoring. Things like smartwatches and smartphones can do an awful lot, but they can't do everything. And so that's another thing that we're considering, and it adds to the clinical utility.
Perfect. Thank you, John. Alex, do you want to dip in on that? Or?
Yeah, I guess related to what John had just said, and also the previous question, the pods themselves are designed to be IT hard and software agnostic. So if we had to accommodate, if you wanted a particular touch screen, for example, because it's in a public space where you can make it really simple for the users to come along, log in, by entering a code or something like that. We're not tied to any particular technology from that perspective.
Perfect, thanks, Alex. Paul's raised a good point here, to be fair. How do you overcome the clinicians' reluctance to use the booth? In Paul's experience, the office is more preferred. So how would you kind of overcome that?
So, I mean, for us, it's about the comfort of the patient as much as it is about the comfort of the clinician. And the bulk of our clinical office space is actually open plan. And so unless you're getting clinicians to work from home, and actually that's something that, that's fine, and that we can factor that into the ongoing model of how we deliver remote consultations. But there will be some clinicians who will need to deliver it from our estates, and that's partly because of job planning requirements. They may need to be there to do a face-to-face clinic immediately after, and so we don't want to be in a situation where we're using existing clinical space, a surgery room, for patients to deliver remote consultation. It's not a sensible use of space. And so in that situation, it pushes us to use these, and it almost becomes a requirement because you can't do it in an open plan office space. Yeah, but then it's also about job planning clinicians to say, well, we have the feedback is this is fine and it's actually really comfortable, but I wouldn't want to be in there for more than a session because they felt a little bit claustrophobic, and that's totally fine. We're not saying that you have to be in there for the full day. It's how you job plan the clinician to use it.
Perfect. Cheers, John. Alex?
Yeah, no, as John said, I think a big part of this is the change management piece, so that we're introducing a different way of working, and we found it with our clients in the corporate sector, and we're finding it with our clients in the healthcare and NHS sector, that needs a specific change management piece to make sure that we remove any fears, any reservations, any challenges that the users give us feedback on, but also that we, as John said, we make the space available, because ultimately this is a bigger picture we're trying to deal with here. This is creating the opportunity so that clinical space doesn't become the restriction on the number of clinical consultations we're having.
And I think it's important to recognise as well that actually visibility of these, I mean, we intentionally put it in the main atrium of our trust headquarters so that people would see it and ask the question, what's going on here? And I've had a lot of inquiries saying, well, can I have a pod? I want to do this, this and that. So actually, people are interested, and I don't, in practice, I don't think that's going to be that much of a concern.
Yeah. You're never going to please everyone, are you, really? But as long as you're getting the majority of clinicians up for using it, and obviously not wanting to be there for 8 hours or 12 hours a day, then, understandable, really. Thank you for that. Last question. Richard has asked, we've already touched base on it, but great way to kind of end. Given the COVID is still around, is there a need for ventilation in the pods or a gap between users? Just touching base on that sanitation again.
Yeah, good question, and absolutely. So as we mentioned, the pods are a kind of plug and play type solution. So everything, the ventilation, the lighting, that's all part of the system. So we've got a continuous flow of fresh air being brought in, and obviously stale air being extracted out of the pod. So every 3 to 4 minutes, you're getting a complete air change of all the air within the pod. So that's an important part of the user comfort in any environment. But of course, during COVID, we've also been looking into, with some of our corporate clients, the opportunity of a UV cleansing additional module, which would actually scrub the air through a UV light as it comes in. But what we've found is that the majority of the clients we're working with are doing that with their overall air handling systems and their overall ventilation systems for the office. So the air that we're actually talking about is the same air that everyone's breathing anyway. So they're just, the main thing is continuing the circulation of cooled, clean air into the pod, and obviously removing the stale air from the pod.
Brilliant, absolutely brilliant. Well, Alex, John, amazing stuff. The engagement has been super high. Really loved it. Are we okay to share the slides post-conference with the audience as well?
Yeah, absolutely, yeah.
Absolutely amazing. Well, again, thank you both for joining us. Absolutely brilliant. And yeah, cheers again, chaps.
Good, thanks for having us. Thanks,
no problem. Pleasure's ours. Thank you. Right, everybody, just